This is part 2 of my video cast on keywords related to anatomy in the generic clinical section of the in-training exam. Additional relevant information can be found in part 1 and in my video cast on lung sliding. The highlighted keywords are the ones that will be addressed in this video cast. The spinal cord is perfused by 2 posterior spinal arteries and 1 anterior spinal artery. The anterior spinal artery provides about 75% of the total blood flow to the spinal cord. The anterior spinal artery begins as a fusion of vertebral arteries, reinforced with 6 to 8 radicular arteries, the largest of which is the artery of Adamkiewicz. This illustration nicely shows the radicular arteries, but does not accurately represent the source of the artery of Adamkiewicz. This illustration shows the origin of the artery of Adamkiewicz. Note that in 75% of patients, the artery results from the fusion of radicular arteries T9 through T12. The range, however, is from T5 through L5. There are consequences for this configuration. With 1 anterior spinal artery, there is essentially no collateral circulation. This leaves the portions of the spinal cord perfused by the anterior spinal artery at risk for ischemia in the event of the disruption of blood flow, such as may occur with cross-clamping during aortic surgery. This image shows the areas of infarction with different cord lesions. For anterior spinal artery syndrome, the area of infarction includes descending corticospinal tract, ascending spinothalamic tract, and autonomic fibers. In the acute phase, the patient presents with loss of motor function, deep tendon reflexes, pain sensation, and temperature sensation. Because autonomic dysfunction may also be present, hypotension may occur. Proprioception and vibratory sensation remains intact. Although it's unlikely to be the subject of a question on the exam, it's important to note that over the period of days to weeks, spasticity and hyperreflexia may replace flaccidity and loss of deep tendon reflexes. This table presents data regarding the risk of anterior spinal artery syndrome associated with various aortic surgical procedures. The risk associated with endovascular procedures remains unclear. Questions regarding this content are commonly presented as a clinical scenario in which a patient underwent a surgical procedure with a risk of anterior spinal artery syndrome and also had an epidural placed. The issue is to determine the etiology of the patient's problems. Based on the acuity of the presentation, the history alone is generally sufficient to rule in or rule out an epidural abscess. The ability to answer the question and to differentiate between epidural hemorrhage and anterior spinal artery syndrome requires knowledge of the previously described manifestations of anterior spinal artery syndrome. The absence of back pain is another clue to the etiology. The next subject to be addressed is caudal anesthesia. The sacrum is the result of the fusion of the 1st through 5th sacral vertebrae. Administration of drugs into the caudal epidural space occurs via the sacral hiatus. A fibroelastic membrane representing the ligamentum flavum covers the sacral hiatus. The sacral hiatus is located at one point of an equilateral triangle, with the other 2 points being the posterior superior iliac spines, which are located at the level of what would be considered the 2nd sacral vertebrae. The other anatomic landmarks essential for performing a caudal epidural anesthetic are the sacral cornua, which represent the spinous processes of the 5th sacral vertebra. The sacral hiatus is located between the cornua. Most recommendations are that, following the usual maneuvers to assure sterility at the puncture site, the needle is inserted at a 45-degree angle and gradually advanced. As the needle penetrates the sacrococcygeal ligament, a pop or loss of resistance will be noted, indicating that the needle tip has entered the caudal canal. Once the needle tip is in the caudal canal, the hub is lowered until it is almost flat. In the adult, the spinal cord ends at about the level of L2, and the dural sac ends at the level of S1 or S2. In infants, the dural sac extends to about S3 or S4. The most common locations for a malpositioned needle are into the dural sac, in which case it should be possible to aspirate CSF from the needle, in the periosteum, or above the sacrum. If the needle is positioned above the sacrum, it should be possible to detect subcutaneous swelling by palpation or visualization. Although currently performed almost exclusively in pediatric patients, as this illustration of pain pathways during labor demonstrates, a caudal anesthetic would provide excellent analgesia for the second stage of labor. The increased vascularity of the caudal space and the relatively large dose of local anesthetic required to provide lumbar analgesia, for example, for stage 1 of labor, have resulted in the technique falling out of favor in general and in the OB population in particular. The final subjects in this video cast relate to the anatomy of the epidural space and paramedian approach. This slide shows the anatomy of the epidural and subarachnoid spaces. I'm hard-pressed to figure out a question on epidural anatomy. One alternative would be showing an image with several structures indicated by letters and asking you to select the letter corresponding to a specific structure, for example, the interspinous ligament. A second alternative would be providing several sequences of structures and asking which corresponds with the sequence encountered by a needle during the performance of an epidural or a subarachnoid block. This illustration shows the differences in needle position for a midline, paramedian, and oblique paramedian approach to a subarachnoid block. The key issue here is that a paramedian lateral approach requires that the needle be positioned at about a 10 to 15 degree angle off midline, but still positioned level with the inner space. Most likely, if a question relates to the paramedian approach to a subarachnoid block, it is describing the paramedian lateral oblique approach shown in the prior slide. With this approach, the needle is positioned about 1 centimeter caudad and 1 centimeter lateral to the inferior border of the spinous process of the vertebral body above the inner space. The paramedian needle is inserted approximately 15 degrees off the sagittal plane. The paramedian approach has the advantage that the patient does not need to be flexed, potentially making it easier to perform in elderly patients. Additionally, the paramedian approach bypasses the supraspinous and interspinous ligaments, which may be calcified in elderly patients. One disadvantage of this approach is that while the midline approach requires conceptual visualization of the sagittal and horizontal planes, the paramedian approach also requires consideration of the oblique plane. Thank you. That's the end of this video cast. I hope you find it useful, and good luck on the exam.